Okay, welcome to the BJANcast, the podcast of the Brazilian Journal of Anesthesiology. And today we are excited to introduce a special issue of the Brazilian Journal of Anesthesiology dedicated entirely to the pediatric anesthesia. This is actually the first special issue of the Brazilian Journal of Anesthesiology, and I'm very fortunate to be the invited guest for this special issue. In this issue, we delve into the unique challenges and advancements in pediatric anesthesia, particularly in low and middle income countries, especially Brazil. And join us today for this BJANcast. We have Anelise Wolmeister and Thomas Engelhardt from Montreal Children's Hospital in Montreal, Canada. Anelise and Thomas are the contributors for this special issue and also experts in pediatric anesthesia. And Anelise and Tom will guide us through the session topics covered in this special issue. And thank you so much for you to be here with us.
It's been an absolute pleasure, and thank you for the opportunity to participate in this top podcast. And it's a very exciting opportunity to see the readership in Latin America and Brazil, and we are very happy to contribute. And Annelise is smiling as well, so I think it's a very happy and bonny day as well.
Yeah, I'm very happy and glad that we could make it. It's very nice to have the opportunity to have lived and worked in these two different countries. And I guess we have a lot of things in common. We have a lot of things to learn from each other also. And I think it's a good way to start.
Great. So thank you so much once again. So to start our conversation here, can you tell us why pediatric anesthesia is considered such an specialized field, and why it's crucial that children, especially those small children, infants, and neonates, receive care from experienced professionals such you, Anelise and Tom, and including myself here in Brazil.
So I'll answer this one.
Yeah, sure.
So we could start with the classical format resident lecture, saying that and stating all the difference between the adults and the pediatric population. And we know that from theory, their particular physiology and anatomy, that we know that they are they have a higher metabolism consumption than adults, meaning that they have higher oxygen consumption and lower reserves, making them a vulnerable population. This is from the physiological side. And from the evidence side, we know also that actually the younger kids, especially the ones under 3 years old, the ones that are sick, and especially ASA class higher than 3, they are much more prone to develop complications, especially respiratory complications during the period. And saying that, of course, they have poor outcomes regarding that.
Yeah, absolutely. And just to underline this message again, fully agree. So higher demands, lower reserves, these children are really vulnerable. But the really good news is that these children don't have to have a higher morbidity or mortality when compared to adults in other specialties if they're cared for by the right people in the right resources in the right environment. And that's what makes the special subspecialty of pediatric anesthesia so exciting and nice, because we actually will have a huge impact on the future of these children. What we do will affect them potentially a lifelong, and that makes really pediatric anesthesia such an exciting and very, very interesting, but also challenging specialty.
Great, amazing. And one of the surgeons here, the pediatric surgeons here in my center, he always said that we are anesthetizing and providing surgery for children that we want that this kid will live for more than 100 years. So our responsibility is huge when we are giving care, healthy care for kids. I think all the pediatric specialties include ours, pediatric anesthesia. So another question for you. One of the significant themes on this special issue is the disparity in pediatric anesthesia care across different regions. As Anelise said, she used to work here in Brazil, in Porto Alegre, and now she lives and works in Montreal, Canada. And could you two elaborate on these disparities and their impact on patient outcomes, especially in low and middle income countries like Brazil and other countries here in South America?
I would say that basically the mismatch between the individual needs and the available resources are a major problem. And I would address also the fact that in terms of workforce in Brazil, because the way in Brazil and most likely in the low-income countries, the doctor is the center of the decisions. So basically, we do not train properly the ones that could help us a lot. And we don't have trained nurses that could bring a much better care for our pediatric patients. And here we have the respiratory therapists, but could be like someone else that helps us dealing with anesthesia. So if we compare like the high income countries, like if you see like United States numbers or European numbers, we would say that like for the anesthesiologist, it's much more comfortable to work because they have a lot of support. When you are in Brazil, like you are in the room, you are the only one and the one expert. There's no one else that will come to help you. Not even the nurses, and I'm not blaming them, they don't know how to help you because we don't teach them, because this is not a culture. And I feel like this is a big problem. Like they don't even know how to hand you a tube. So I would say that this is a major problem that we should think about in the future. I think we should train people to be in our side. Like the workforce in the United States is about 34,000 nurses, anesthetists. If an anesthetist hears this in Brazil, it's like a shame. They are going to take over, but it's not true. We need to realize that working together is working for safety. And it's not, we do not need to be frightened by that. We need to be working together and teaching each other how we can take good care of the patients.
Yeah, absolutely. And if you look at the raw data itself, it's quite evident that if you have a big disparity in outcomes, and if you use, for example, a cardiac arrest as a marker of quality or poor quality of care, data from a tertiary hospital, for example, in Brazil, show that you have at least twice the incidence of cardiac arrest when compared to so-called high-income countries like the States or somewhere in Europe. And similar, it's not just unique to Latin America, I believe. It also happens across in South Africa, where you have similar ones that 1 in 8, 1 in 7 children undergoing minor surgery, and these are healthy children actually, will have serious adverse events during the surgery, which are entirely preventable and avoidable if you have the right personnel and the right resources. And that is, I think, one of the major challenges, and it is almost shameful that this is not being addressed by local. Unfortunately, children do not really have a voice to really say what needs to be done. And this fortunate special issue really addresses this and hopefully will help to highlight this issue, especially, for example, in South America.
Another thing that we could point, I'm not sure how it worked in Europe, Tom, but you can tell us. But in Brazil, we are obliged to have a doctor in the recovery room. So here, like it's a pediatric hospital, and the nurses, they are able and they are good enough and they can take care of the patient. So there's this big discrepancy in the clinical activities and their skills in managing the patients.
Yeah, absolutely. I mean, I've trained and worked in 3 different healthcare systems within Europe and within Canada, and yeah, absolutely. The key really is to empower and enable and teach and train your additional workforce. It doesn't have to be the medic who knows all and can do everything and is the only one who ever knows anything is considered God. No, this is wrong. What really needs to happen is that they need to work together and use the resources, use your allied health professionals, all the other supports that we can get to teach and train and get them interested in pediatric anesthesia and convince them that actually pediatric anesthesia and the perioperative care is actually fun and actually makes a big difference ultimately to the children.
Yeah, this part of your editorial is very interesting, Anelise and Ton. I never thought on this side regarding that in Brazil, anesthesia, it's only a physician privilege. So it's crazy. And in Brazil, we have around 24,000 anesthesiologists, period. And in the US, and Brazil is a huge country, 200 million people in this country. And compared to US is 350 million people. It's almost double. They have more nurse anesthesiologists than Brazil has physician anesthesiologists. So it's very interesting to think in this way, considering that in some situations you the only one. Once when I was in Geneva, and they asked me how is anesthesia in Brazil, and they asked me about the nurse, and I told them the nurse is not allowed to do anything here. They went crazy. So if you are a small neonate or premature neonate, I'm alone. In my center, I'm not alone because I have residents and fellows, but the majority of practice in Brazil, and at least know that, you are alone the most of the time. So to train other colleagues, I think it's very important to increase safety and quality of perioperative care. So very interesting, this conversation. So about the Safe Anesthesia for Every Thought initiative, the Safe Thoughts, you initiated your editorial with a quote from the Safe Thoughts initiative. And it's also a focal point in this issue, especially in this editorial. So could you explain what this initiative is and how it relates to the challenges discussed in your editorial for this special issue?
Yeah, thanks. And I'm really
Tom is the father of the safety thought, so I think he should be the one answering this one.
Well, that sounds too grand. I'm not a father. I'm one of many people who actually just really got concerned at one stage that we are talking about neurotoxicity and speculate on potential harms of done to the children based on drugs alone, whereas actually the safe conduct of anesthesia is really what really matters. And effectively, the Safe Thoughts initiative, which was set up about 8-9 years ago now, really addresses the issue of safe conduct of anesthesia and address the known risks of pediatric anesthesia. And effectively, what we try to do with one is to promote the rights of the child for the highest attainable standard of care in the right environment. And it, like I said before, it was established to emphasize the role of the conduct of anesthesia to prevent harm in the perioperative period and to promote safe and high quality clinical care. Well, if you think about it, ultimately it serves the right of the child And this is the ultimate goal. And this is what I really try to work. And I'm very privileged here in Montreal Children's Hospital to work together with some very talented individuals. This is our DNA. So what we try to do is with the SafeTouch initiative that we set up very prominent, visible, well-known clinicians and academics worldwide to join force for the good and detail what actually does it mean, what is good clinical pediatric anesthesia practice, what are the goals. And one of the most perhaps known ones from the SafeTouch thing is the 10N principle. So what is to maintain homeostasis of a healthy child, or if any child in a perioperative period. So the 10N concept, which is also available, for example, on the website, can be really used to guide your daily clinical practice. And ultimately, what we have taken it further, we put the right of the child in the center of our care all the time, and define good clinical practice. But ultimately, what we do is we define what is a personal institutional competence and what leads to this one and what should you do in your daily practice. Gives you some very practical framework ideas of how you can actually deliver good clinical and safe pediatric anesthesia care. And I think that really was a big decisive moment in pediatric anesthesia when we are able to define this one and come together and work together and motivate people. And then again, when I first started here in Canada, we have been practicing effectively in anything but the name, the SafeTouch principle. This is our DNA. This is how we deliver good clinical care. And I'm very, very privileged with my colleagues who actually work along those ideas. But there's more details. There's more details on the website if you want, and I'm sure it's in there.
Yes, so please visit the website is safetouch.org. It's very straightforward, and there's a lot of materials there, all for free, and it's a very, very interesting material at the website. So I invite all of you to visit the website after reading the editorial. So continue with our conversation. So let's talk about training and education in pediatric anesthesia. So training and education, we know, are crucial for improving pediatric anesthesia care. So how does your editorial address these aspects, especially in low and middle income countries such as Brazil and other countries in South America?
So I'll start this one. So I find that there's a completely lack of initiative, either financially saying and educationally saying. So if we can divide it in 3 different points, I would say. First of all, we have a mixed anesthesia. Like usually you don't have like a specific pediatric hospital, or you just do anesthesia like a tertiary hospital. So I feel like the mixed practice just keep this role going on. Like everybody does a little bit, and you know how it works. You know, it's so terrible that we end up being specialists just because we do more. And it's not wrong, because if we go to the evidence, we see that actually as more you do pediatric anesthesia, as more you practice, for more years you've trained also, better your patient will be much better, in much better hands and safe. But it's a pity that we really don't have an incentive to make people study more years. If you compare like in Europe and United States, in high income countries, the residency is about 4 to 5 years, while in Brazil it's 3 years. So can you imagine like the difference? And on top of that, they still do fellowship 1 year, and Scandinavia, like top of the example, 2 years. So it's a lot of time being exposed and being taught. And on top of that, while they are in the residency and they are exposed to pediatric anesthesia right in the beginning of the training, which doesn't occur with us, that in Brazil it's much more like you are more in the R3 that you are exposed. They also are trained by pediatric anesthetists, so it's a huge difference in terms of training. And why would you be interested in being more and more expertise, like acquiring more expertise, if first of all the payment is shameful? Like a neonate hernia, you know, that like pays much less than a plastic surgery and gives you much more work. It's much more stressful for sure. So I feel like this is a big like point. Second, we don't have like a regulation for that. Like no one is seeing like and seeing like, are you keeping your skills? Do you have skills to do this? Like I feel like there's no regulation. And yeah, I think this is the most important thing. Like it's well proven that like the apricot and the other studies show that like the dedication of pediatric performance, less than 73 days in your year. If you do less than 73 days, you are not good enough, I would say, but like you have more chances of having cardiovascular events and arrests in the pediatric population. So we should be looking for these numbers and making sure that we don't let this happen. But we will have to find a way to build it and make it like official, I would say.
Yeah, absolutely, and fully supported that. I was almost surprised that at the end of your comments there when listening to the reality, but I've heard that from you before. But I mean, I trained and worked mostly in the UK in my post-cardio training for 25 years, and there's very simple. Children belong to a children's hospital. And I think that simple philosophy that children are cared for, so actually the child comes first, and not the surgeon, not the surgical specialty, only because a child has an orthopedic problem and needs to go to an orthopedic hospital where the surgeon likes to operate on anything from an adult hip to major knee replacements to whatever. And also, we also have a little bit of an add-on of pediatric work to do, and that is wrong in the first place. And actually, from a child point of view, from a experience point of view of the healthcare system, it's a much better experience for the child, for the family, and also has better outcome. And that has actually been shown that as a consequence of the restructuring in the UK that happened in the 80s and 90s and 2000s, that pediatric centers have really established a very, very good resource and a very good quality of care. You can always argue then maybe everything should be done always in a pediatric center, but logistically that might not be possible. So we need to find a very good balance in how we train and maintain expertise in case emergencies arise and situation arise where delivery of the best standard of care isn't possible. So we need to work, and there are some very good examples. And having worked in Scotland, we have a Scottish network where we do outreach clinic, we have simulation, where we invite colleagues from other hospitals to come and work with us, who then go back to community hospitals and work there. And the same we're practicing here in Canada as well. So we have a lot of colleagues who come and work with us on a daily basis who have an interest in pediatric anesthesia, but train with us, getting exposed to good clinical care, and then go back to on a daily basis to the community hospitals and then deliver care. And for example, Anelise is one of the prime examples as well. She is one of the pediatric specialists who visits the under-resourced areas in Canada. So she and one of her colleagues is going up to the northern regions in Canada to deliver pediatric anesthesia care to under-resourced one. So there are different options, a lot of ways how we can actually deliver care, but also make sure that the expertise and the skill set in those areas is available. And I think solutions are there, but it needs to get the buy-in. And I think ultimately what is required is that we put the needs of the child first. And that's what really matters. And make sure this is our future. There's always a quote that say children don't vote, so we don't really need to care for them. I think that's a wrong approach. What we need to do is we need to really make sure we need to invest in the future. We need to train the staff in education and make sure that we have the resources available to make sure they have the best start in life.
Yeah, it's also very tricky here in Brazil. We have a few children's hospital in Brazil, as Anelise know. São Paulo is a huge city. We have 13 million people here in the city and 21 million people in the metropolitan region of São Paulo. And we have only 3 children's hospitals. So it's impossible to give care for all these children with a few hospitals. So the majority of children in Brazil, they are anesthetized in general hospitals. So in your editorial, you discuss this matter, especially as Thomas said, to train our colleagues in these general hospitals to be able to give care for those children and try to take a very small children, a very complex disease, and transfer this child for a children's hospital because it's better. And I think we must adapt because, unfortunately, in Brazil, we won't have enough pediatric hospitals for all the children that we have here. And I think it's very important for other low middle income countries as well in South America.
So as you mentioned, like it's written in the editorial, like that at least if you have a mixed hospital, but if you are planning to receive kids anyway, you should have at least one pediatric anesthetist on call to be able to attend this kid, you know. So if you cannot have a pediatric hospital, at least you can have a person dedicated only to the pediatric cases. Like in my previous hospital, we didn't have the luxury of having it. So it was very tricky because during elective cases, yes, we could choose people that liked more and do more pediatrics and are more comfortable, but on call days, no, you can't. And then there's this person that never wants to do pediatrics and they are never comfortable, but then they are doing calls and then there's the case and then what, you know? So, and we really tried to make it as a pediatric group, but because of the budget, it was never possible to go in ahead.
It's amazing. So to have one pediatric anesthesiologist is on call for general hospitals. So this is a very probable solution for our hospitals here in Brazil. So we are almost finished our conversation here. So future directions and solutions. So in your opinion, to improve pediatric anesthesia care globally, what do you propose and what solutions or future directions to try to improve the pediatric anesthesia globally?
Well, I think we need to work together and we need to combine the resources and expertise in putting the right, like I said before, of the child first. If we focus on this as a starting point, then we can work from there. And what I learned as well, talking to Anelise and to yourself as well, one of the biggest problem is that you need to, when you work together, you need to join forces, which means that you need to have a professional society who has an interest in pediatric anesthesia. And I actually was surprised to hear that Brazil, compared to other Latin American countries, doesn't have one. So maybe that might be something that you may want to consider. And I think you have a lot of talent and a lot of very excellent and dedicated people in there who need to happen. So you need to join, I think. And from that point of view, from there you can build a platform to educate, train, set guidelines, protocols, and adapt them on best clinical practice and make recommendations that are specific for each individual country. like for example, Brazil, and that could also be extrapolated to other areas under-resourced across the globe. That would be similar in Africa. That might even be true for the higher income countries. Even though they have a lot of money, it doesn't mean necessarily they do good care. I don't want to name names, but there are areas that they can potentially improve as well. And we all need to be humble. We need to work together, need to know why we do pediatric anesthesia. And that is for the best interest of the child. And as long as we put their needs first, then we can actually use this one. And like I said to you before, the Safe Tots initiative gives you a very powerful framework to lobby for this one, and actually helps you to relay that message to your administrators, to your people who hold the budget strings, to your head of departments, to give them very simple, clear idea what needs to be done, and just to gives you idea to open the discussion. Why do we need this one? And rather than having it as, we don't really care about kids because they're not really worth doing, but gives you an idea how you can work towards the goal to achieve best clinical care. That's what I think should happen. It sounds very lofty, but I think it's practical. I think it's feasible. And having worked for the past 5 years here, I think we can see a change. And talking to my colleagues worldwide, there is the urge and the need has been recognized to look at good clinical care. And everybody wants to do exactly that. And we're there to help. And we need to work together to achieve this.
Great. So to conclude, what message you like to leave to our listeners and also the readers for the Brazilian Journal of Anesthesiology, especially regarding this special issue in pediatric anesthesia? So Anelise first, and Tom.
So basically, if you give anesthesia in the right hands, you can have wonderful results. I believe that it doesn't matter. It's not because you are rich or not. It's not a matter of equipment. We have access to equipment in Brazil. I think it's much more a matter of knowing what you're doing and having the skills to manage that. You need to know how to use your equipment. You cannot be stuck with that like thing, oh, it's because I'm a poor country, so I can't. No, I don't believe in this. I think we can always be better.
Yeah, absolutely. And pediatric anesthesia in the right hands with the right amount of resources can be very, very safe. There is a good chance to improve and really avoid harm in these children and provide the best possible care. But I think if we work together, we can achieve this one. But it requires investment of resources financially, but also requires personal resources, human resources, and a lot of efforts from our side. And the onus is also on us as pediatric anesthetists to go out and train and teach and relay the message to this one. And again, thank you very much for inviting us to this podcast and for this special edition of the Brazilian Journal of Anesthesiology. Hopefully, that is one of the first steps to achieve exactly that. And I'm looking forward to really work together and see how it all falls out. And we're there to reach and discuss and really help along this way. So you're one of the leaders in Brazil, Vinicius, so very proud and very happy to work with you. So I hope we can achieve this.
So thank you, Anelise and Tom, for sharing your expertise and give us a preview of this amazing tutorial that you wrote for our important special issue, the first special issue for the Brazilian Journal of Anesthesiology. And thank you so much. It was amazing. And we encourage our listeners and also the readers to dive into the Brazilian Journal of Anesthesiology to read more about these topics that we discussed here. I think all the papers are already published because we have a continuous flow publication for the Brazilian Journal of Anesthesiology. So go to our website, BJAN-SBA BJAN.org, and you find all the manuscripts there. And also, don't forget to subscribe to our podcast, and stay tuned for more insightful conversations. So until next time, thank you so much. Bye-bye.
Thank you very much. Bye-bye.
Bye.